Okay, good morning, and thanks to the organizers for the opportunity to present at our inaugural masterclass. Jared, can you guys hear me?
Yes, we can hear you.
Okay, perfect. So I'd like to thank Prof. Mohamed and Dr. Zamparini, and especially also Katikane for all the efforts in putting together this program. And the theme of obesity for our first masterclass is definitely an important one, because training of obesity at both an undergraduate level as well as a postgraduate level is suboptimal. And despite all of us seeing patients that are obese in our practice every day, I think most of us are still quite uncomfortable when it comes to managing patients that are obese. So I've been asked to discuss specifically the role of medical therapy in obesity. And I think if I was asked to do this a few years ago, there probably wouldn't be much to discuss. But with major advances that have been made in the field of obesity, we finally have alternative options to bariatric surgery. So I hope to inspire you all, and I hope to change your mindset when it comes to obesity medicine. So with regards to the outline, here we go. For the first half of the talk, I'll be taking you through the global burden of disease, as well as brief definitions, as well as the impact of obesity. We'll go through some goals of weight loss, as well as the treatment approach. Of course, we can't understand pharmacotherapy in obesity unless we actually discuss the pathophysiology of obesity. So I'll try and keep it as basic and as simple as possible. And lastly, we'll end off with where the future lies and some basic recommendations. So where are we? In 2016, over 2 billion adults globally were overweight. Of these, 650 million were obese, and that's with a BMI of more than 30. The worldwide prevalence of obesity nearly tripled between 1975 and 2020. An estimated 3 to 4 million deaths per year are from obesity. So if the problem continues at this rate, we'll have nearly half of the world's population being obese by 2030. Where do we lie within a local context? 70% of our women and 40% of our men are obese or overweight in the Sub-Saharan Africa. South Africa has the largest proportion of obesity in Africa, with a BMI of more than 30. And where do we stand globally with regards to South African females? We have the highest severe obesity prevalence amongst females globally, and this is with regards to a category of a BMI of more than 35. So if these stats aren't alarming enough for you, obesity isn't limited to adults. In Europe, 1 in 3 11-year-old kids and children are overweight and obese. A study done in Africa showed that 12.8% of urban dwelling primary school children were obese. So these numbers just highlight to us that we need to start acting soon. When it comes to obesity, there's this misconception that obesity is simply a state of calories in and calories out. Losing weight is just simply about the calories, but there's more to it. We need to start, we always tell our patients, eat less, exercise more, and I think we're all guilty of this. We tell our patients, have the willpower to lose weight. But I think it's important to remember that obesity is more complex than this. It involves an interplay of numerous hormones, an interplay with regards to the gut microbiome, altered gut-brain communication, as well as genetics and epigenetics. So I hope that by the end of this talk, we realize that we cannot will ourselves to lose weight. With regards to the classification of obesity by BMI, BMI is a simple index of weight for height that is commonly used to classify overweight and obese adults. Overweight is defined as a BMI of more than 25 to 29.9, and obesity as a BMI of more than 30. Despite the limitations of BMI as an index of obesity, it's still the recommended measure in most guidelines. But we're starting to use and recommend waist circumference to be used more. And these are some of the different waist circumferences. I won't spend much time on this, but the reason that waist circumference is recommended is that it's much more accurate in terms of a measure of the cardiometabolic risk and mortality that is associated with obesity. So what is the impact and the health implications of obesity? Generally, we all tend to focus on the cardiometabolic risks and associations in terms of obesity. We all talk about hypertension, diabetes, heart failure when it comes to obesity. But I'd like to highlight that we should not neglect the wide range of obesity-related diseases, especially the ones that we fail to address is fertility, and that's both in males and females, as well as mental health issues. These include depression and anxiety. We must definitely not forget the associated musculoskeletal complications, especially when it comes to activities of daily living and the reduced quality of life associated with it. So all of these obesity-associated metabolic complications brings me to the very first important concept of today's talk, which is obesity is a chronic disease. And however, despite us recognizing that obesity is a chronic disease, it still remains the most undertreated chronic disease. And this is a study that was done in the United States between the years of 2010 to 2019. And if I can show you the figure on the left with regards to anti-obesity medications being prescribed, the most common was that of phentermine and duramine, and we'll discuss that later in the talk. But as you can see, we're not doing a great job. Prescribed in just over 2% of patients. With regards to other drugs, just about 0.5% in terms of prescriptions. So for what chronic disease will this ever be acceptable? Is this acceptable in hypertension, diabetes, even HIV? This will never be acceptable in any of the other chronic diseases. So we need to start doing better when it comes to obesity medicine. The other thing is, are we making the problem worse when it comes to obesity? So we sometimes prescribe medication that can also cause weight gain. So I think the important message is assess the concomitant medication that a patient is taking as a possible contributor to weight gain, and sometimes consider alternatives. So we also are guilty in terms of diabetic treatment. Insulin, sulfonylureas are usually also the ones that can cause weight gain. So I think the message here is review the indication for the medication and always look at the patient in terms of weight. So we're all aware of the strong association of the rising BMI, as well as the rising incidence with regards to diabetes. And I think the key concept that was coined, and the term that was coined from the early 1970s, is that of diabesity, which essentially is diabetes and obesity. So there's a strong association of obesity and diabetes, suggesting a causal pathophysiological link between both the phenomena. The question is, does encouraging weight loss in our diabetics or even our pre-diabetics have any benefit? This is quite an early study, which is the DPP, the Diabetes Prevention Program, where patients, I think it was over 3,000 patients that had impaired glucose tolerance on an oral glucose tolerance test, were randomized to receive either metformin, intensive lifestyle modification, and placebo. And they achieved weight loss of between 4 to 7%. Patients basically showed a reduced progression in terms of type 2 diabetes in both the lifestyle modification group as well as metformin. So weight loss does reduce your progression to type 2 diabetes. The question is there weight loss and improvement in other comorbidities as well? So these are also studies basically with regards to diabetes and pre-diabetes, and essentially shows a 23% reduction in terms of progression to diabetes. So we look at goals of weight loss in improving comorbidities. And this is the recommendations from the American guidelines of obesity. And one begins to see improvements as early on as just 3 to 5% when it comes to lipids and triglycerides. But the important message is the greater your level of weight loss, the greater your improvements in terms of your medical comorbidities. Modest weight loss of between 5 to 10% can be seen with improvements in systolic and diastolic blood pressure. But it's important to note that some comorbid conditions may require much more weight loss, even 10 to 15% or more when it comes to obstructive sleep apnea and non-alcoholic fatty liver disease. And we've got a session today by Dr. Mohamed from gastroenterology, and she may shed more light on this. What I haven't shown here is that modest weight loss of between 5 to 10% is also associated with an improvement in terms of healthcare costs and reduced healthcare costs. So the expert panels basically recommend goal weight loss of approximately 10%. I would say target a total health improvement. Don't focus on a number or be prescriptive in terms of percentage weight loss, but start off at least with focusing on health improvement. So how is weight loss achievable? The therapeutic model in obesity is that of a tiered approach, with lifestyle intervention and behavioral therapy forming the cornerstone of this model. However, for many patients, lifestyle intervention isn't enough. So we have the second tier, which is pharmacotherapy, which the majority of the talk on will be today. And we've also got endoscopic procedures and surgery. What's important is that it's always difficult to achieve weight loss with purely these measures. And the reason for this is not only based on adherence, but also because we have a certain set point, which I want to discuss today. So energy is homeostatically controlled, and this brings me to this set point theory. Whether we are lean or whether we are obese individuals, weight is homeostatically controlled. And it's not as simple as we eat until we're full, but weight is controlled by the brain. And I'll expand on that today. Our brains maintain us at this set point of body weight, which is maintained consistently over our life. The brain detects signals of fat, energy status, nutrients, glucose, and then it uses that information to either increase or to decrease energy expenditure to maintain us at the set point. So if I can put it simply, if we start losing weight, our bodies are then wired in a way to increase food intake and to reduce energy expenditure, which makes weight loss challenging and difficult for our patients. So this is why we then can't achieve this with diet alone. We need to assist our patients with pharmacotherapy to then help them reduce appetite. So this brings me to the pharmacotherapy on the second half of the talk with regards to obesity. So where are we in our timeline when it comes to anti-obesity medication? How have we done? And over the last few decades, our timeline with regards to anti-obesity medication doesn't look great. Since the 1900s, we'd had thyroid hormone preparations, and that was taken off the market for obvious reasons. Arrhythmias, thyrotoxicosis, DNP was taken off the market. We had amphetamines introduced since the 1930s, and we then had phentermine introduced as early as 1959, that's Duramine, and that's been approved for short-term use. However, off-label, many have been using it for longer-term use. Fen-phen, or fenfluramine, which many of you may have used in the past, was taken off the market in 1997 because of pulmonary hypertension and valvular heart disease. Sibutramine was also withdrawn and taken off the market in 2010 because of cardiovascular events, specifically heart attacks and strokes. Rimonabant taken off the market because of mental health adverse events, specifically suicidal ideations and depression. So all we really were left with is Orlistat, which is still FDA approved, and that was introduced in 1999. But we'll go through the adverse events with it. So many patients still don't tolerate it. Then we had Locasiran, introduced in 2012, unfortunately also recently taken off the market 2 years ago because of a signal to cancer. We have phentermine topiramate combination, which is FDA approved. Then we've got our diabetic drugs, of which is approved for obesity at a higher dose, Saxenda, liraglutide. And we have the combination, Contrave, which was a combination of Naltrexone-Bupropion, approved in 2014. And we'll discuss this a little further later on. And the reason is that it's just been launched in South Africa last month. What's exciting for us, and you can see the big gap between 2014 and 2021, that's a 7-year gap between the approval of another FDA-approved drug, is that we've got semaglutide, Wegovy, and that's been approved at a higher dose in June 2021 in the States. Unfortunately, we don't have it approved yet in South Africa, but we do have it being used for diabetic indications at a diabetic dose. So for a drug to be approved and FDA approved, it needs to meet the following criteria. It needs to induce a loss of weight of more than 5% at 1 year, or more than 35% of patients should achieve 5% of weight loss, and it should show improvement in metabolic biomarkers. That includes blood pressure, lipid levels, and glycemic control. What are the indications currently for anti-obesity medications? It's a BMI of more than 30 or BMI of more than 27 with comorbidities associated with excess body fat. And these include diabetes, hypertension, and dyslipidemia. This is not an all-inclusive list in terms of comorbidities. And as if you can refer to the American guidelines, they will list multiple other obesity-related complications in terms of severity as well. So the FDA drugs that we've got for long-term use are the ones listed, and for short-term use, we only have Duramine. But it's important to note that we have many using off-label use with regards to drugs that are designed for other conditions like diabetes. For seizure control and migraine, we still have topiramate that's being used off-label, and whether or not it's actually beneficial and causes significant weight loss is questionable. Depression and smoking cessation with bupropion, and naltrexone, which is then for addiction. So looking at the mechanism of action of these anti-obesity medications, I've simplified it to act essentially on 3 targets. And this is based on energy status, energy expenditure, energy loss or energy or absorption, and energy intake. So when it comes to expenditure, I think we all would love a drug that can just melt our fat away, but unfortunately we haven't been really successful when it comes to that. So there was thyroid hormone and DNP, which I said has been taken off the market. With regards to energy loss, we've got SGLT2 inhibitors and orlistat. And the way SGLT2 inhibitors work is it's a diabetic drug with the loss of glucose in the urine, so essentially losing calories. And I think where most of the work, and to draw your attention to for the rest of the talk, is this class in terms of energy intake. And the way it works predominantly is that of the central nervous system. But an ideal drug would be one that combines all these strategies together. Some may even consider obesity to be a neurological disease. So over the next few slides, I'll take you through a very simplistic, basic pathophysiology of obesity so that we can understand the pharmacotherapy. So this is a cartoon diagram that I put for you simply to understand that the central nervous system controls and integrates the peripheral signals from the gastrointestinal tract and then adapts this based on our nutrient and energy status, and it then acts via the hypothalamus hunger center. Genetics are also important in this. Within the hypothalamus, we've got the lateral hypothalamus, which is our hunger center, and we've got the ventromedial hypothalamus, which is our satiety center. The important region within the hypothalamus to draw your attention to is that of the arcuate nucleus, which is the first order neurons. And we've got a paraventricular nucleus, which is the second order neurons. So looking specifically at the arcuate nucleus, we've got AGRP, NPY, which is orexigenic, and this increases food intake and reduces energy expenditure. We've got POMC-CART, which is anorexigenic and decreases food intake and increases energy expenditure. So these neurons are then inhibited or stimulated by peripheral signals. Ghrelin is the only hunger hormone which basically stimulates AGRP and NPY. And ghrelin, being the hunger hormone, is highest just before a meal and stimulates appetite and hence increases food intake. Then we've got adipose tissue, which releases insulin and which reduces leptin, and leptin then reduces food intake and increases energy expenditure. So looking at the second concept today with regards to food intake, I'd like you to draw your attention to this mesolimbic hedonic reward system. And this system is influenced by our dopaminergic and serotonergic pathways. And the reason I want to draw your attention to this is that the mesolimbic reward system is extremely important because it overrides the hypothalamic hunger system. So for example, after a meal, you may have reached satiety and be full, but you can always make room for dessert. So you may then be offered a slice of chocolate cake, and the mesolimbic reward system is what allows you to override that hypothalamic hunger system. And this is what causes hedonic obesity. This is essentially what that resets that set point that I was talking about and contributes significantly to obesity. So to put it together, we've got the three systems for food intake. It's the mesolimbic system, the prefrontal cortex for executive function, and the homeostatic hypothalamus. So by understanding how most of the drugs work, we can now look at the efficacy of therapy. And for most of the FDA approved drugs, until now, there's been a modest loss of weight, between 5 and 10%. And if you actually need to look at it with regards to drug placebo weight loss, it's about between 4 to 7%. So there's definitely a treatment gap. And over the years, we've seen that there's noticeable gap between the efficacy of pharmaceutical therapy for weight loss and the gold standard of bariatric surgery. And until recently, metabolic surgery has been the mainstay therapeutic intervention to show significant weight loss with resolution of metabolic comorbidities. So the question is, how is it that we can bridge this gap? And I will then introduce the incretin effect. So this is GLP-1 receptor agonist, and I'm sure most of you are familiar with this from the diabetic field. The GLP-1 receptor agonists have revolutionized the management of diabetes and is currently leading the way in obesity management. So as a background, GLP-1 is a naturally occurring incretin released from the gut in response to a meal. And for those of you junior in the audience, the incretin effect is when an oral glucose load produces a greater insulin response when an IV glucose infusion is given. So the differences in response are attributed to GIT peptide GLP-1 and GIP. In terms of the mechanism of action, most of us know that it usually results in a decrease in gastric emptying, as well as a decrease in gastrointestinal motility. But what's important is the CNS effects. And I take you back to the pathophysiology slide. And as you can see, there is a direct activation of POMC-CART. So it reduces food intake and it increases energy expenditure. And it indirectly inhibits AGRP and NPY. So ultimately reducing food intake. This is a summary of all the diabetic trials in terms of GLP-1 receptor agonism. And all you can really need to take from the slide is that as a class, there is weight loss. So the red bars is the drug semaglutide and the yellow bar being liraglutide. And so briefly, I'm just going to go through the scale trial from liraglutide, which showed modest weight loss of 6 to 8%. But to draw your attention to the right, I think is important because as you can see, 63% of patients had more than 5% of weight loss, and a third of patients had more than 10% weight loss. Almost 15% of patients have more than 15% weight loss. So what's important here is you can see there is great variability when it comes to weight loss. And that introduces the second important concept of this talk, which is that obesity is a disease of great heterogeneity. No two patients are the same. Every patient will respond differently to a drug. And so that's important to remember. So another GLP-1 receptor agonist is semaglutide, which is an exciting new anti-obesity medication with great efficacy. And so we have the STEP trials, and I'm going to take you mainly through the STEP 1 trial, which was a series of trials that were designed. Semaglutide 2.4 milligrams was given subcutaneously, and this was issued once weekly. And this is not the same like liraglutide, which is given daily. This was together with lifestyle modification, and the endpoints were looked at week 68. So you can see that the mean body weight change after week 68 in STEP 1 trial was 14.9%, with a treatment difference of 12.4% as compared to placebo with lifestyle modification. Over 86% of the semaglutide group lost at least 5% of their body weight compared to 31% in the placebo group. half of the participants had at least a 15% total body weight loss, and 1/3 of participants achieved 20% of weight loss. So this was quite amazing result that we have not seen before with the other anti-obesity medications. And so this is something that we are now seeing that can possibly rival the efficacy of bariatric surgery. So there were numerous step trials. I'm not going to go through all of them, but just to draw your attention to step 4. And the reason for that is that with regards to pharmacotherapy, eventually there comes a point where the weight loss plateaus. But with the step 4 trial, continued use of semaglutide resulted in continued weight loss, whereby 40% of patients had continued weight loss, about approximately 8%. And the other important concept here is to see that when the drug is stopped, which like most other anti-obesity medications as well, there is about 7% weight gain. So again, it's a chronic disease. We need to continue the medication long-term, because as soon as we stop the medication, the weight gain will recur. So this is the last drug that I'll be reviewing today. And the only reason I'm doing this is because it was just recently launched in South Africa at the end of Feb. And it's the combination of Naltrexone-Bupropion, also known as Contrave. And the way it works, and I mentioned in the pathophysiology regarding POMC, but the precursor POMC is broken up into alpha MSH and beta endorphin. Now, alpha MSH binds to melanocortin-4 receptor, and this results in a decreased appetite and increased energy expenditure and weight loss. Beta endorphins act through the mu-opioid receptor on the POMC neuron. And to put it simply, this acts almost like a brake on the POMC neuron. So it results in reduced activity of this POMC neuron. So the reason that the drugs need to be used together is that naltrexone will then prevent the beta endorphin-mediated POMC autoregulation, and bupropion stimulates POMC neurons to release alpha MSH. So thus resulting in a synergistic activation of the neuronal activity and reduced food intake. So this shows that if you use the drugs individually, so given naltrexone alone, it's almost just like placebo, not much weight loss. Bupropion alone, about 3% weight loss. They have to be given together to achieve that synergistic effect. And the trial that was done was the CORE1 study, which showed about a -6% in terms of weight loss as compared to placebo. So given the multifactorial pathogenesis of obesity that we've seen, there is variability in response to therapy, and thus there definitely is a role for novel therapies to fill this treatment gap. So there are drugs in clinical development and many novel therapies ahead in the future, of which I'm only going to be focusing briefly on one group, which is going to be that of the incretin class, because I think that that's the future in obesity medicine. I call this the twin cretin effect. And until now, most of the anti-obesity medications all focus on a single molecular target. The new classes are multi-agonists. And as we mentioned earlier, GLP-1 and GIP are two primary incretins. And the dual insulinotropic effect maximizes the glycemic benefit as well as the anorexic effects of GLP-1, and they restrain any potential obesogenic effects of GIP. With regards to the trial, it's tirzepatide from the SURPASS-1 trial, which showed an 11% reduction in terms of weight, and 27% of patients had about more than 15% weight loss, about 47% achieving more than 10% weight loss, and 77% of patients more than 5%. But what's important to note here is that weight loss occurred as early as 4 weeks. And if you look at it at 40 weeks, it wasn't plateauing. So they're still having ongoing weight loss. So this is where the future is. We're going to have dual agonists in terms of GIP and GLP-1, as well as GLP-1 and glucagon. And look out and watch the space in terms of GLP-1, GIP, and glucagon triple agonist therapy. So to tie it all in together, I'll end off with this recommendation from the Canadian guidelines. And we basically would assess the indication for anti-obesity medication. We have a patient that would be then diabetic, prediabetes, hypertension, And then you look at your options in terms of then using either liraglutide in those patients. What's important to then note is that you need to make an assessment at 3 months to assess if they have weight loss. The first concept to note here is that if there isn't significant weight loss, you need to then either consider changing the drug. If there is weight loss, it's always important to remember to continue maintenance, as this is a chronic disease. If they have predominantly craving or depression, we can consider going with the Contrave route. And I think the other important concept to note is that because of the heterogeneity of disease and not every patient responds the same, we may even also need to consider combination therapy as well. So to end off and put it all together, we know that I brought in 3 important concepts: that obesity is a chronic disease. Always remember lifelong therapy until there's a cure. It's complex and relapsing. So continue with maintenance therapy on these patients. It's got great heterogeneity. And so not every patient, but it's not a one size fits all approach. Every patient is going to respond differently. And the take home message is that one of the biggest barriers to obesity intervention is ourselves as physicians, that we are scared and there's the stigma. We fail to initiate therapy at the appropriate time post pharmacotherapy as well as metabolic surgery. So we need to shift our focus to emphasize that obesity is a disease, and it's a disease that carries great morbidity and mortality. The second is that of combination therapy, and the synergistic effect of combination therapy is, I think, the beginning of a paradigm shift in the management of obesity. A new era in the treatment of obesity is on the horizon, and the gap between bariatric surgery and pharmacotherapy can be traversed. I think it's important, and Prof. Mohamed mentioned this in the introduction, is that obesity, even in the absence of the metabolic syndrome, is an important risk factor for cardiovascular disease, as well as mental health illnesses, and a multidisciplinary approach is important. And what's important, because of the heterogeneity of obesity with the variability in response, the future lies in precision medicine. We probably will be going ahead in terms of hormonal profiling, genetic profiling, and we may even be able to then predict which pharmacotherapy may benefit individuals most. So I thank you for your attention, and I'm happy to take any questions. Are there any questions in the chat box?